general somatic health. Two examples from cardiology. You know that we all know that if you have depression, that it interferes with a lot of risk factors in diabetes, in hypertension, in stroke, in cardiac things, etc. That it influences also how once you got it, how the evolution will be clinically. Well, this is here taken from Delolet in the Netherlands. They're taking 800 patients, over 800 patients, with a stent implantation. 2 years prospective follow-up, and looking in these 2 years, who's going to die or having a myocardial infarction despite having a stent. Overall, this was about 4% in that group. If they had a baseline diabetes, double, 9%. If at baseline they had no diabetes and no risk factor, no diabetes, but lack of positive affect, the same risk factor as having diabetes. And you have both diabetes and reduced positive affect, and you end up with almost 70% of mortality or myocardial infarction. So a very strong predictor. And in their multivariate analysis, they controlled for negative affect, depression, anxiety, and that was less important than the positive affect. So apparently, cardiac health is very important. Second study, 2013. They did now, is what they call the Heart and Soul study, 10-year follow-up of 1,000 patients with stable coronary heart disease. What did they find? That each standard deviation increase in positive affect was associated with a 16% decreased risk of death. A very strong effect. When they adjusted for the cardiac disease severity and for depressive symptoms, it remained statistically significant. But if they adjusted for physical activity, doing sports and fitness, positive affect was no longer, it was still trend, but no longer significant. What does that mean? That means that it's maybe not only the positive affect as such, but it could be due to positive affect, you also exercise more. And you know that exercise has been shown to be protective against depression. And of course, you don't know in these kinds of analyses, you don't know if it's because you exercise more that you have more positive affect, or you have more positive affect and then you will do more exercise. Probably it's certain, and it's not just an linear interpretation that you should have. So in cardiology and cardiac health, lack of positive affect is stronger related to outcome than excess of negative. And we psychiatrists, we are strange people. We are considered to be logical, and we are not always logical. We are maximum psychological. I said, it's a core criterion of depression. Can you explain me why that we say for depression, the two core criteria are depressed mood and anhedonia, and then we're going to look at outcome and we don't look at it. It's weird. If you look at the Hamilton, 17 items. If it's a core criterion, there should at least be 3 items on positive mood, on anhedonia. That's not one. There's just one score of one item that slightly refers to it. Loss of interest and activity, hobbies or work, the score 2, in the item number 7, work and interest. And for the rest, we don't talk about it in Hamilton. If you look at the MADRS, not much better. Now it's 2 scores, also on 1 out of the 10 items. Reduced ability to enjoy usual interest, loss of interest in surroundings, loss of feelings from friends and acquaintances. And that's it. So we say it's very important for the definition of a disorder, and we don't look at it. I cannot explain that. And it is important, because the way you look at things decides what you're going to see and what you don't see. I love photography, probably several years, also loving photography. We all know if you have a 24mm lens, wide angle, you see different things than if you take a 200mm zoom or lens or a tail lens. So the way you look at things defines what you're going to see, what you're not going to see. If I hear the 200mm lens, I don't see the cello. If I have a 24 wide angle, I see him completely. This is just to show that sometimes, if we don't use the right scales, we don't see the things. using scales can be an art of lenses in a hall of mirrors. If you look at the Hamilton, this is just one study, agomelatine versus venlafaxine, with the standard 50mm lens. What do you see? Hamilton, no difference at all. Both are very efficacious in reducing depressive symptomatology as measured with the Hamilton. But in that study, there was also the SHAPS, Snaith-Hamilton, Anhedonia, and Pleasure Scale. Same study. And now you see, after 1 week, a dramatic difference in the advantage of agomelatine in restoring the hedonic function, in reducing the anhedonia. And this is maintained after 2 weeks and after 8 weeks. So you have another lens, and you see a completely different picture with differences between treatments. Remember what I said when I started my presentation, that in fact in the 80s and the 90s, or after 2000, the overall efficacy is about the same. Although you are clinicians and you treat patients, so you know that the antidepressants are not the same. But as long as you stick to such general scales as a Hamilton and a MADRS, what regulatory bodies ask companies to do, we don't see the differences. Moreover, it's maybe not only that they have a different mechanism of action, but it could also well be, I'm just asking you a question, who recognizes the case vignette I'm giving you now? You treat a patient suffering from depression with an SSRI, whatever one. And the patient comes back and says, doctor, I feel much less depressed, but I have the impression that things don't touch me so much. I'm a little bit more distant from my emotions. If you listen carefully to your patients, you're going to hear that. And they say it's as well towards the negative as towards the positive. It's like there's a kind of bit of a restriction of the emotional range. This is a very typical serotonergic side effect. There's now, in Australia, there's also just done by Red, also on 1,500 patients complaining exactly about the same thing. The first study who illustrated that was from Pedro Delgado's group, Uproot, in 2002. That's already a long time ago. And what they found here, these were all patients in full remission with an SSRI, but complaining about sexual side effects of the SSRI. You know, the prevalence of drug-induced, antidepressant-induced, SSRI-induced sexual side effects is about 40 to 50% with SSRIs. And they looked at those, and they looked at the emotional intensity of these patients compared to healthy controls. What did they find? That those on an SSRI cried less, were less irritated than normal controls, less sad, less anger, less worrying. The message could be, we all should take SSRIs because we are better than the others. But when they looked at the positive emotions, they feel that they were less caring about others, that they were less creative, less open to surprise, and less being able to express their emotions, and that we don't want. This was really the first illustration of this restriction in the emotions, as well in the positive as in the negative. Could it be? No, and before I say could it be, just showing this has been looked at with agomelatine, and I'm going to say something more about the mechanism of action, versus SSRIs. And this is escitalopram, very good antidepressant, versus agomelatine. And looking just at this emotional reactivity, my emotions lack intensity. More than 50% say so with escitalopram, and 20% say so with agomelatine. Or things that I cared about before my illness don't seem important to me anymore. Well, 40% with an SSRI, and less than 20% with agomelatine. Again, you see, overall, with Hamilton, you don't see, or you see minor differences, but you look at other things, emotional intensity, and you see dramatic differences. Could it therefore be that if we treat a patient with an SSRI, that's the upper part of the slide, so the patient is depressed, so has an excess of negative effect here in yellow, and has a lack of positive effect in blue. You treat your patient, you reduce the negative, you increase the positive, and this is your final state, where you have a balance, a critical balance between positive and negative,